Welcome to Module 4, covering gender and sexism. In this module, we'll look at gender differences, for example, between men and women in terms of risk factors associated with poor health outcomes. And we'll look at the experience of sexism, how this particular experience expose women or place women at higher risk for certain conditions. There's a substantial research to show prevalence of disease conditions, differential prevalences for both men and women, and also we see gender differences in early detection of certain conditions between the two groups, as well as prevention of diseases and types of treatments that are provided between men and women. So there are diseases that are associated with different conditions or outcome that are associated with different disease condition among men and women. For example, heart failure has shown to be much more related with coronary heart disease among women than men. Cardiovascular diseases also differ between the two genders. With moderate to borderline hypertension associated with greater risk of CVD in women, and smoking associated with a risk of acute myocardial infarction, which is basically a heart attack, more so in men in comparison to more so in women in comparison to men. So additionally, women have higher prevalence, for example, for type 2 diabetes in adolescent compares to males. Women with this condition have a greater risk for CVD complication. So based on these differential risk conditions, we see that, gender has been categorized as a social determinants of health because of established differences between men and women in terms of risk, in terms of outcome. Accordingly, there has been a lot of research aimed at addressing differences in risk factors and outcomes between men and women. So let's think about this case scenario, because as I mentioned in previous lectures, the application of these concepts of the content you are exposing to is really important. How these things can be used to address the disparities we're seeing among groups. So for this case scenario, an annual report assessing both disease prevalence and incidence rates in 3 rural communities show that higher rates of HPV rates among women aged 21 to 45 in comparison to men of the same age. Reports for the past 3 years show an increase of 15% in newly diagnosed cases, so that's a marker of incidence rate among women, while trends show 5% among men. So HPV is place folks an increased risk for cancer, both men and women. So essentially, it is an important public health concern. So think right now, you are being part of a research team developing an educational program to tackle this issue. But first, before intervening, so what are some key information that you need really to increase the likelihood of developing an effective program? As I mentioned in lecture 3, module 3, it is our ability to intervene effectively, and intervention is basically some examples of that. Health programs targeting a certain behavior or certain conditions for a particular patient population, for example. So one example could be helping newly diagnosed patients with type 2 diabetes understand nutritional behaviors that are associated with a poor glucose control. So understanding how adhering to your medication and making behavioral changes such as dietary changes and exercise, and also managing your level of stress how these things are important in managing this condition. So that would be a program that aims at intervening in decreasing the likelihood of folks not managing the type 2 diabetes normally, therefore increasing their risk for so many other chronic conditions, including premature mortality. So essentially, before you intervene, you have to know, you need to know more about the factors, interactive factors that are associated with your target, with the target behavior. So in this case scenario, it's HPV vaccination, and so how would you think about some key information you would need to increase the likelihood of intervening. And these things, and anything that comes up to your mind, it's likely a good idea, right? Before we intervene, what would we need to do? What would this look like in terms of making sure we get information that really is crucial for developing a program that the target population actually will use? Because essentially you can have a program that looks great, but if it's not meeting the needs of individuals, then it's not likely to be utilized. So one of the key things that are done, not just public health, in any type of scientific based program or intervention, is formative approach. Especially when you are developing something fairly new or something somewhat novel, you need to know a lot about the rates. For example, in this case scenario, so understanding the rates of HPV vaccine among men and women, right? Because we have an incidence rates, differential incidence rates among men and women. It's higher for women in comparison to men, based on the scenario we just reviewed. So you need to know what are the rates of HPV vaccine among men and women. What you are seeing, is it because there's differential vaccination, which is very much likely to be one of the contributing factors. Attitudes towards HPV between these groups. Attitudes or beliefs about femininity, acceptable strategies for increasing vaccination intake, and level of sexual assertiveness. Why would these things be important? Because when a lot of established research show, when we are doing formative research so formative research is essential for developing a program that really include the voices of the target population. Of course, you start what's there in the literature, so rates of HPV vaccine among men and women, you're likely to have that at least at the national level. Overall, there's a lot of research on that. And you can actually get it at the community level if you're focusing on a certain community. You may just use the local hospital or the local community center, whatever your target environment is. But also, it may be that even when you see the differential rates, okay, let's say men tend to have higher vaccination rate more than women, which is, there's not really a lot of research, because women to HPV vaccine tend to have been really targeted among women, and it was not later on that actually HPV vaccine were made available to men. And HPV vaccine tend to be targeted for age group between 21 and 45. This is where if you're vaccinated within that age range, you tend to have much more effective protection against risk for certain cancers, associated cancers. So attitudes toward HPV vaccine between the groups is really important, because there's research to show that there's some misinformation around that if I allow my daughter who is a teenager, who's an adolescent, to get this vaccine, am I saying essentially that you're able to, engage in sexual activities, because these are things, HPV risks are transmitted through sexual activities. But this is not necessarily the truth. It's more of a protective factor. Talking about vaccination does not necessarily mean that parents are giving their consent for children to engage in sexual activities. It's more preventative later on. And attitudes and beliefs about femininity. Should you be making this decision? There are few research studies that have looked at that these beliefs about these vaccine in certain groups. Women don't make, some women may not feel like they want to make the decision about the getting these vaccinations based on the fact that the decision is not made by women. In this particular research we've seen, and acceptable strategies for increasing vaccination intake. One of the strategies for doing this typically is education, but also education is important, of course, understanding that, okay, it's, allowing your daughter or your son to be vaccinated, allowing your daughter to be vaccinated is not necessarily really, giving the okay for sexual, giving you permission for them to engage in sexual intercourse or engage in sexual behaviors, but rather it's prevention later on. But also understanding what are some barriers to, and even when you're educated, what are some barriers to HPV vaccine, and access is also important. Level of sexual assertiveness was also one of the important factor, especially when we are looking at gender differences in certain conditions that are associated with sexual behaviors. Because similarly to condom use, so condom use, as they are associated with decreased risk of HIV. There's a body of research. One of my mentor in graduate school, Patricia Marikoff, is one of the national experts on sexual assertiveness and sexual behaviors. In her work, show lack of sexual self-efficacy. Self-efficacy is basically our perceived ability to engage in certain behaviors when faced with certain barriers. So lack of self-efficacy to be assertive with partners was one of the barriers, for example, for condom use and other protective measures, and that's associated with HPV. So understanding, is it lack of for women who may not want to take the vaccine, and other protective factor, not as protective as the vaccine, but protective sexual behaviors, protection using condom and other protective behaviors can also be can reduce certain risk for HPV. So these are things that would be essential in affirmative research that really aims in developing a program that addresses the barriers and potential facilitators of HPV vaccine intake. Annual checkup that includes HPV screening between men and women. Perceived sexism is another. So going beyond gender differences, because we see the gender differences, it explains the disparities, but it's really important because it gives us a starting place to understand what's going on in terms of differences we're seeing in a condition among men, and versus women, and why this is important. So, sexism and health outcomes. So it's not being the identity of being associated with identifying as women is associated with certain adverse experiences, and sexism is one of them. So basically, the sexism is defined as, interplay of action and practices by the dominant culture that has really shown to really put women in a subordinate role. So perceived gender discrimination. So women who report gender discrimination has shown to also report physical and mental effects, and those include depression, anxiety, headaches, and gastrointestinal symptoms. So these experiences are not just experiences that women have, and they have no effect. They have the effect of sexism is shown in so many various conditions that plague women who have these experiences in comparison to those who do not report being a victim of sexism. Heart attack is often underdiagnosed of women, and one of the reasons for that is sexism. So sexism, when women are accessing the medical system and getting help for certain presenting symptoms, their experiences, how they're treated is not the most effective, and that goes into have shown to be related to why certain conditions like cardiac ischemia is often underdiagnosed among women. We also have low rate of early detection or recognition of this disease condition in women compared to men. And women receiving treatment for heart attack by male physicians tend to have greater risk of mortality if they are treated than those who are treated by female physicians. So there is sexism is not just happening in the workplace, although if it's happening in the workplace, it also can have dire effects on women's health. But also when women are seeking treatments, that experience can impact how providers respond, and therefore certain treatment that are given in how decisions that are made in terms of treatment approaches. And delayed treatment for this condition has shown to be higher among men in comparison with women. So if you are having this very serious condition and treatments is being delayed, you can understand why you will see this higher mortality rate associated with this condition in comparison among women in comparison to men. And women tend to receive less evidence-based treatments, and that these are some of the things that you've seen in your readings for this week, for this module rather. Evidence-based treatments are evidence that are shown to be much more effective for the particular conditions than others. So if you are giving something that is less effective, you can absolutely understand why the outcome may be much more dire for women than men. And we see sexism, the disparities in terms of the use of evidence-based treatment. The research has shown is associated with sexism in healthcare. So Burrell et al. Found high levels of discrimination were associated with higher scores of health-related measures among women, and particularly, they assessed perceived sexism as positively associated with perceived health, poor health, and physical injuries in the past 12 months, as well as smoking rates among women. And whenever you see a positive relationship, a positive correlation, it means one way to perceive it is that as perceived sexism increase, so are poor health, self-perceived health outcome, mental health, and injuries of past 12 months, as well as smoking. So it's basically a linear relationship. They also found that the relationship between perceived sexism in these outcome measures, including poor mental health and smoking rates, were associated by country of origin as well as social class or social class. So what do you think about, these moderators? And as you may remember, moderators, it really explain an interaction effect among variables. So think about the relationship with variable A and B varies at the level of variable C. So social class, you can kind of understand that social class may come with a higher perceived self-efficacy for women to advocate for themselves when being faced with sexist experiences, versus if you are, if you're high SES, you're more likely to feel like you can advocate for yourself versus in others, versus if you're not, if you have low SES. That's not always the case, but we see there's evidence of this. And more so, if you're of low SES, you're less likely to be in fear of, okay, if I were to do this and get retaliated against, I'm more likely to lose my job, therefore lose that income. And unfortunately, oftentimes the person is working, it's probably the breadwinner of their household. So that might be a hindrance from reporting sexist behaviors versus those who are from different social class. Country of origin can be explained because there are certain countries where there are policies that have been enacted to protect women's rights. So with those countries may be associated with higher perceived self-efficacy to report these behaviors versus other countries wherein policies against sexism have not been enacted, and poor treatment of women very typical. So Burrell et al. 2008 found perceived sexism to be associated with poor mental health. Being employed was associated with higher levels of reported sexism. For women who were employed, they had higher rates of sexism, meaning it's quite possible the source of sexism is likely coming from in the workplace, because being employed is associated with that. Recommendation for mental health for interventions targeting these women should consider how gender discrimination is an underlying factor in presenting symptoms. And this is really important, as we've talked about lived experiences in a previous module, how our lived experiences can impact our mental health and physical health. And that's really essential when we're interacting with patients, however, at whatever levels we're interacting, to think, okay, what are some experiences that might explain the presenting symptoms that we're seeing in patients, and therefore should be part of the treatment protocol that we choose, because these experiences may impact the efficacy of the treatment that you are providing to the patient. So if the core, the source of, these, let's say, mental health presenting related issues are not addressed, you might be missing a really important construct or important source that really could be vital in really fully, effectively helping the patient. So thinking about, because we know that sexism is so prevalent, so when we do meet with women's patients, should part of the assessment be also assessing for potential experience of sexism or gender discrimination. So indeed, the one of the articles that you read for this module is proposing, should we be not just gender, but sexism as a social determinant of health? Should that experience itself be a clear social determinants of health. And I absolutely agree. So let's look at case scenario 2. A large number of women in comparison to men in a conservative town were presenting with seemingly epileptic seizures at the local emergency room hospital. Functional MRI and other neurological testing, however, show no effect on brain structures during this episode for women. So people were trying to, the providers or doctors were trying to determine, is there some structural factors that explain why we're seeing these seizures among these patients, and they found there were no brain structural factors. So there is no biological explanation to why this is happening or structural brain structures related to that. So a curious clinician administered a gender role scale and found that women had higher endorsement of conservative gender roles and belief. Moreover, a higher number of seizures were associated with higher scores on that gender role scale. So what might be the underlying factors between men and women who are presenting with different epileptic seizures at the local hospital? What might you want to explore to better understand this phenomenon? Again, this is where these questions and scenarios I'm using is really to get you to think about beyond the differences that you are seeing between men and women. What are some of experiences? What are some beliefs? What are some other attitudes that may explain why you're seeing this? So these are scenarios that reflect real life research studies, real life that inform different programs that were developed to really address these problems and similar problems when based on gender differences that some providers were seeing or researchers were seeing between men and women presenting in different emergency room hospitals. So why my gender roles, strict, very conservative gender roles, be a contributing factor or predictive factor, in high rate of seizures among women. And so I'm going to use my clinical example to really help understand that. So in my work and in other clinicians' work, we were seeing that a lot of women that were presenting with similarly neurological symptoms. And these symptoms include the fact that they felt like they could not move a certain part of their body, and it was interesting, but there were neurological bases for it based on various neurological testing. So these symptoms present at neurological, and they were not malingering. These women were not, doing this to were not lying. They were not feigning their symptoms. These were clearly symptoms that they were experiencing, but however, there was no neurological basis for them. So they were not there. So based on that, okay, there are no logical basis, then it must be psychological. And this is why I emphasize the importance of understanding the impact of our lived experiences on the mind and the body. And what we saw is that these neurological experiences were associated with certain really very strict attitudes. So you had a subgroup of women who, some of these patients were, they were the head of the household in terms of being what women should be responsible for. They were in very conservative and patriarchal household where the man governs, and I'm not criticizing that, but I'm just giving you context to understanding their presenting symptoms. So their failure to be effective in these, effective in whatever chores, the role that we're doing, we're being associated with neurological symptoms. And psychological intervention were helpful in helping these women recover. So without understanding that, okay, there are certain experiences, because whenever you have patients presenting with seemingly medical symptoms, you have to partial out whether or not there is some medical explanation in terms of brain structures for it. And if you've partial that out by conducting different tests and conducting, different clinical interviews with the patient or relevant family members, then it's important to think about what about, the experiences of this patient might give you insight to presenting symptoms. And we saw that these seizures were not structurally based, but they were psychologically based. So exploring, what might really help you explore this phenomenon and understand it, and therefore help to treat it, is asking the questions about what about the experiences of women that might explain that. And that's is why an understanding of the literature is really important. If you are a provider and you're not aware of the literature, then you may miss the mark. These women may just go underdiagnosed, undertreated. So in these these seizures have an impact on not just the mind, but physiologically, even though the causes of it is not just some structural base. So the other side of sexism. So we've talked about sexism, but through experiences, as we are exposed to various experiences, we might turn to internalize them as being intrinsic to our identity. And that's with any group. It's not just, sexism, racism, homophobic treatment. It might be that the group that is being treated in such an inhumane way, some members essentially become to internalize these experiences. So internalized racism, for example, how it's measured among women, sexism, internalized sexism, so measure items, a woman's places in the home, not in the office or the shop, is better if the man is the achiever, is the one who's bringing home the bacon. If you're a vegan, just say vegan bacon, I don't know. Or the woman takes care of the family. Women should share the work. So these are items that measures whether there's an internalized racism. So your different response to some of these item measures may indicate that if there is evidence of internalized racism. So men should share the work around the household with women. If you endorse that, this is an item that may differentiate that, there's not really high level of internalized sexism. So I'm just giving you some measure items and particular measures that are used to measure internalized sexism, and these are detailed in some of your readings. So why this is important? Because that goes into the very conservative role that I had mentioned in previous scenarios. These conservative notions at times may lead to some internalized sexism. That we internalize these behaviors, these attitudes that are meant to put women in a subordinate role. I am not saying that whether you think of women's places in the home, that is your preference, but the goal, the focus of this is to think about how these experiences may be impacting how we function daily, and the potential contributing roles and presenting differences in presenting conditions, and the understanding of them as being important in how we engage with different individuals in our day-to-day work, as particularly with patients. So other is women are much happier if they stay home. Again, it's another item. And so do these items adequately measure sexism? Think about any measures that you are being presented with. So a measure is basically a construct. It's a construct that should be that indicate these are the items that are necessary to measure the particular construct. So sexism is a construct, happiness is a construct. And certain constructs, you can pretty much directly assess them. And some you need composite measures to assess them. So do these measures adequately really assess sexism? So as you read a measure, whether or not is scientifically based, you as a critique of the scientific literature, it's important to see, okay, would these really, assess the overall experiences of sexism for women, or even for certain women subgroups, different demographic groups? So it's important to see if these items really assess the lived experiences of sexism, or internalized sexism rather. So maladaptive coping mechanism to survive from contextual factors associated with internalized sexism, strongly associated with psychological distress. And also there's correlation that increase the likelihood that experiencing trauma or experiencing a traumatic event. So internalized sexism place individuals who are higher on the scale, or whatever scale that are being used to assess internalized sexism, we see there's some associated health outcomes with that. It's also in contributing factors and for multiple traumas, for experiencing multiple traumas. So these experiences that we as some group are part of over time may lead to internalizing them, are also associated with various health outcomes, or place us, of course, in increased risk factors for various experiences. So a recap: gender differences in disease prevalence and outcome, it can be a result of sexual sexism that impact treatment of women in various contexts, including medical treatment. Assessing sexism and not mere gender differences is really important in really understanding experiences that might underlie presenting symptoms, and therefore that should be part of treatment or considered for treatment approaches. Not just sexism, but internalization of sexism. The strict attitude also may have shown to contribute to comorbid disorders in patient populations. So it's important to really consider them as we look at in our interaction with patients, in the scientific literature, when we look at women's health and risk factors. And so these might be some moderators that impact internalized racism. Might be a moderator that we need to assess, that may show differential relationship to why a certain women respond to an intervention while others don't. So how do we really assess internalized sexism and really leverage them as a way to address disparity among men and women? So here are some additional references, and thank you for listening or watching. I will see you in the next module. Bye.